Thank you very much, Karen, and thanks for inviting me to speak today. I was just reflecting a little bit when Kathleen and Chris were talking. It's now about 35 years since I stopped being a civil servant in Northern Ireland. And I was reflecting that I couldn't have done this talk 35 years ago because it would have been all completely pointless. The notion that the government decision-making process would be seeking guidance and support from an evidence base was so far away from the agenda that you might as well have just hidden away in a room by yourself and talked to yourself, because that would have been just about as effective. So I'm very pleased that we have now moved, I think, towards a different stage. Some of you may have been forensic enough to see that I didn't put palliative care policy and practice in the title, and indeed one of the themes I want to develop is that this is about out of hours, this is about palliative care, but it's also much more importantly about the way that the palliative care system interacts with the wider health and social care systems. And without seeing the evidence as trying to inform the development of palliative care services in this context, I think we will lose a lot of opportunities that are important. Before I go further, please, anyone who's ever worked with me, shut your eyes in case you're not on my list here. But the great thing about working in teams is you don't actually have to do the work, and other people do it largely for you. And most of the evidence I'm going to be citing, at best I would say is a teamwork, and at worst I only had a small part in it. So what do I want to try and talk about? Well, I want to start with why we have moved from what I call insight and passion to evidence and science, because the early developments of palliative care were largely driven by great insight and great passion, but relatively small amounts of evidence. I want to think a little bit about where we are and where we're going, what works and for whom and how, and understanding what's good value, because talking about the economics of palliative care, which I'm meant to do nowadays since I joined King's and they put it in my title, is quite difficult because people don't instinctively like the idea of being involved in economic issues around palliative care, crucial though they are. But I also want to touch a little bit on trying to focus on what people want. Again, a somewhat revolutionary idea, but it's become quite fashionable recently actually to find out what people are looking for in the system. And then talk a little bit about how we might use the evidence in policy and practice. Anyone who doesn't recognize the two pictures here, this is the moment where you go off and study by yourself until you get to a position where you do know who they are, because you are here under false pretenses. These, of course, are Mary Aikenhead, probably the most influential character ever in the development of palliative care, and Dame Cicely Saunders, who I was privileged to know a little bit in her later life, and who even when she was supposedly in her declining years wasn't declining at all. So, moving from insight and passion to evidence and science, roles for palliative care, as we've heard from the earlier speakers, are rapidly changing. We've moved beyond end-of-life concerns towards understanding that whole trajectory of needs through the development of life-limiting disease, the need to control symptoms, but more importantly, the need to plan for the wishes and goals of individuals to be met as much as possible. We're working more and more in this context of multiple health conditions, people with complex disease and complex needs. And this is a theme I want to come back to briefly, because this complexity has moved us from relatively simple and straightforward processes to, I would argue, very complex ones. And we're increasingly understanding that all of this has to be in close cooperation, not only with other health and social care professionals, but also with families and the wider support community. So what are we trying to do? Well, we're trying to optimize experiences for people with complex needs requiring high levels of skill and teamwork. That's the goal, I would argue. That's where we're trying to get. That would be a good outcome. This is made more difficult by the fact that the healthcare system in most countries is moving towards narrower and narrower specialism, where people are less and less able to think in a broad way and less tendency to work in teams. So the underlying environment is getting more difficult, and there are all sorts of good reasons why someone should only know about one bit of the heart and not the other bits of the heart. So they're really good at that bit of the heart. But it'd be quite nice for them to contextualize it within a human being who actually has other bits of their heart as well as having lots of other things that may be wrong with them. And so we are not sitting in a static situation. We're sitting in a situation where the general trend in the health system is actually still making it more difficult to do the job that we should be doing. And this is obviously presenting challenges for older people's services much more widely, and not simply in palliative care, but particularly across the primary care, hospital care divide. And I would say divide because that is still very much what it is. And looking at the current evidence, a lot of what we're doing within palliative care is well supported by evidence, but quite a lot of it is not, and I want to focus obviously more on what is not than what is. Ireland, as has already been pointed out, and this applies north and south, has one of the more developed systems of palliative care across Europe. I was quite interested recently doing some work with the Swiss Federal Department of Health, and they were simply setting out now to say, what can we do to begin to catch up? I wanted to whisper under my breath, you don't just want to catch up, you really want to overtake, because we're only part of the way there. Access to palliative care, as has been pointed out, is uneven across the country, and we need just to establish what these patterns are as clearly as possible, and that to quite a large extent has been done through a number of different studies. But the Tilda evidence, and I think this is horribly powerful evidence, suggests that about half of decedents die without adequate pain management and without adequate management of mental health issues. If you said to people half of the population is not getting effective management of important symptoms, that seems like quite a lot. You agree that's quite a lot if you have half who are failing. How much it's failing is not clear, and we need to understand that more. How much of these problems are in fact amenable to better management is not clear. So I'm not suggesting simply we've got it all wrong. I'm just saying there is evidence there that what we thought were fairly primary objectives within palliative care are only partially being met. We've also had reference to the fact that the number of deaths is set to rise rapidly. It depends what date you take, how rapidly it's going, but I think a fairly simple metric we should be working on is the need for palliative care. That's to say the numbers of people with palliative care needs will roughly double by 2050. Not a bad estimate, it'll just be about double. So when I was talking to the hospice CEOs a few years ago, I wanted to ask them to look out the window and say, you're going to have to do this twice. Of course, I don't think they would do it twice in terms of the buildings, but in principle, we were looking to double the activity in something like that proportion, albeit probably with very different patterns. People will be dying older with more chronic diseases. It will be more complicated because they're more likely to have issues in the treatment of their multiple conditions in larger numbers than they have at the moment. So what do we know what works? Well, one of the big problems in palliative care research has always been what you're comparing it to. What are you comparing a service to? Because it's very difficult to say, well, let's look at this versus normal care, because normal care doesn't really have a simple definition. So we're always going to have difficulty in working out what the evidence should be relative to what would otherwise be happening, because what would otherwise be happening is not nothing, but it's often very difficult to define. Measurement tools have always been a problem around quality of life and quality of experience, and what we do know is widely used measurement tools only partially pick up the important differences people declare, and I'll talk a little bit more about that in a moment. It's very important for us to understand and take account of the effects of different trajectories of care on the wider family as well. And again, very often it's difficult to support a family through this process. Now, any of you who have lived, as many of you have, with the need to manage support for an elderly relative who is coming towards the end of life will know that the real underlying problem is every time you get it wrong, the situation changes, so you've no longer got it right. So every time you get it right, sorry, got that wrong. Every time you get it right, you find it's no longer right because the circumstances have moved on. And I remember in the case of my brother who had Down syndrome, and when he was coming towards the end of life, we kept having little family celebrations that we'd got it all sorted, only to find a couple of weeks later it was no longer sorted at all. So one of the great lessons is any improvements in palliative care provision have to be very sensitive to the underlying changing conditions and be sensitive to the changing needs that will arise through that. Of course, there are some constraints in the kinds of studies we can do. In the same way, I've always argued I don't want to be in the control group for the appendicectomy trial. I think a lot of people don't want to be in the control group for some randomized trials we might do in palliative care. We have to recognize there are some study designs that, however desirable, would not be considered acceptable. But often they are acceptable. And I'm involved in a couple of randomized trials at the moment within palliative care. And in both cases, I would say we have equipoise. We are not going to do bad jobs for those in the control groups. So we shouldn't be shy about trying to improve the quality of the evidence we can provide there. But we must recognize that a lot of studies will be observational, because that's all that will be possible to do. So what do we know about what works and for whom? Well, people here won't be surprised if they've ever spoken to me or listened to me. Perhaps, yes, listen to me. People don't get to speak to me much. If anyone has listened to me, you'll know that I am very obsessed with the question of careful planning and decision-making. And I've been working with colleagues for a long time looking at the effects of specialist assessment teams on what happens to people afterwards. And we know that the more complex someone's needs, the more difference it makes to take time and to have specialist teams working to change the trajectories of care. We know it works. We know it changes things, and we know it changes things for the better. This is, as I say, particularly the case with people with a cancer diagnosis, and that seems to be because cancer gets overtreated more than other diseases are overtreated in the end-of-life period. That's to say, it's not recognized how many people are dying with rather than of cancer. And if we look at the data, it's very clear that those with cancer are more liable to have unnecessary treatment than people who don't have cancer. But anyone with very complex needs is likely to be overtreated in some of those areas with negative effects. And we know that it's particularly useful to look at the assessments early in the trajectory of care rather than later. And I think Kathleen already mentioned this in her words earlier about the importance of getting the whole trajectory of care into the decision-making process rather than picking up the bits after things have started to fall apart. So just giving an example, the work we did with Owen Tiernan and colleagues in St. Vincent's showed that putting palliative care decision-making into an emergency department setting changed what happened to those who were known to have palliative care needs, but who otherwise would have bounced around the system, being reassessed and rethought and overtreated and inappropriately treated, and then go back round the cycle again. So we know we can make a difference by improving decision-making. And we also know that supporting informal carers allow them to switch from doing things that they have to do because they have to be done to doing things they should be doing because only they can do it. We have quite good evidence now that people providing support to someone near the end of life typically have something like a time budget for care. And they will use that time budget either for things that are urgent or things that are important. And the more we provide formal care to support those things that have to be done, the more they're able to do the things that are important but are not in the same way so urgent. We also know that this so-called choice between living longer and living in better health is often not the case. The evidence is increasingly showing that this dilemma doesn't exist anymore. It's not a matter of throwing in the towel. And obviously some of you will be very aware of Jennifer Temmel's work, which has shown that certain people with lung cancer lived significantly longer if you could only stop them being treated. So we're beginning to see this dilemma is going away. We can be thoughtful in our decision making and move away from the notion you either do palliative or you do curative. It isn't any longer really a dilemma. We need also to understand what's good value, and good value and cheaper are obviously not the same, but if something's cheaper and does just as well, then obviously it is good value. So we mustn't be afraid of things that save money, but equally we mustn't be focused only on doing things because they save money. But we know that there is significant scope for savings where people are otherwise getting expensive but largely futile interventions. And we can understand more and more who these people are from some of the big observational studies that have been done. And given the context and types of complex interventions, it's very often difficult to demonstrate the effectiveness of palliative care using conventional measures, but we can show that people have preferences for the improved trajectories of care that we can put in place. Underlying all of this, it's important to know what people want. And I think we have a lot of insight now into what people want in broad terms, not necessarily in terms of each individual and what they're looking for. And when we start measuring preferences and looking at preferences, there are some really quite important outcomes, I think. One is that people want good, timely, low-hassle access to skilled services. And this is absolutely central to the theme of today around out-of-hours service. People really don't want to bounce around the system. And one of the things that's interesting is that people don't want to trade this off with other legitimate goals of palliative care. They're often saying it's not that we want to get it absolutely right 2 weeks on Thursday. They want to say we want engagement now to help us plan and manage our progress through our needs and through our illness. And I think it's very important to understand the importance of process as well as the importance of outcome. And again, any of you who have been left hanging on a telephone with music you didn't choose to listen to for very long periods while you bounce around trying to get towards someone who can at least be interested in your problem will know exactly what I'm talking about. People really care about process. Just in case I didn't make that point, people really care about process. They do like good outcomes, but they're really interested in a good process that leads towards it. And when we start looking at ourselves, I think we can often not stand over the processes we have, even if there is good intention. My grandmother, who was a very judgmental person, she came from a very rich family. I think that allowed her to be very judgmental. And she would always say of me, the intentions are excellent, but the execution is poor. She didn't think that having good intentions was nearly good enough. And I think we have to be very clear here. The evidence suggests having good intentions, but doing bad process can be at least as bad as not having good intentions. At least if you're engaging, that will make a difference. The other thing we have to recognize is that preferences are not stable over time. And again, we've already had reference to, I think, very important general understanding that people do not want to die in hospital context. They want, if possible, to die at home or in a lower complexity setting. But of course, that preference does sometimes change. And when we look at patterns of deaths, it's quite interesting sometimes to look at how those preferences have also changed. I take that as an example, not because I think in general we shouldn't be aiming towards people dying at home, but we have to recognize that circumstances change so fast that we have to be flexible and recognize that these changing needs may be there. We also know that, and this is stealing Bridget's thunder a bit, but luckily she's talking about something quite different later. We know that proxy decision makers, family members, don't always have the same opinions as the patient themselves. And it's very tempting sometimes to listen to the next of kin and not hear the voice of the individual who needs the care. Sometimes it's similar, quite often it's not quite the same, and we really need to be sensitive to that. So what's the conclusion of this little part? Well, it's very important to focus on process, to understand that the approach and style taken may be considered at least as important. People may be just as interested in knowing that someone cares and is trying as to know that they've got answers. Very often they won't have answers anyway, but if they show concern and focus, that will make a difference. Now, I'm going to suggest that we, from now on, ban the notion of specialist palliative care and generalist palliative care and all these other things that get bandied about, because I think it takes away some of the clarity of our thinking. This is a team game, and that team can have different compositions, but that team game has to be seen as a team game. Palliative care is both specialist skills, but it's also a way of thinking and an approach, and it's an inclusive approach where saying this is a specialist group thing and this is a generalist group thing, I think makes only a little bit of sense. I think we need to be moving much more to saying, let's get the right amounts of specialist skills into the right decision making with the right teams in the right context. But what we do know really is that palliative care is really just a version of good integrated care. And I come to a point I always like making: the healthcare system is out of line with palliative care. People often think palliative care may be out of line with the healthcare system. I think it's the other way around. I think people within palliative care have got a general understanding that you can't do something sensible without seeing it in a holistic team sort of way. And where the evidence, I think, takes us is that we need better decision making to make more patient-focused decisions that will take longer and will require more thoughtfulness and will yield less waste and less inappropriate care at the end of it. We have to, therefore, I think, see all the development of palliative care as being closely related to the development of better integrated care across the system. And I think, again, I was very pleased to hear that Sláinte care discussions are very much the context in which that people are looking in this jurisdiction at the future development of palliative care and how we can feed the evidence into the development of services. We know that careful, thoughtful, timely decision-making improves outcomes and improves trajectories of care, so we really need to focus quite a lot on that. And that's not to say we're not interested in the content. Do you give the right drug? Do you give the drug at the right time? Do you give the right therapies? Are all important questions. But I think we need also to look very much at the style of delivery, because that's what people care about to a large extent. The evidence suggests there are at least, I think, 3 urgent needs in policy making where the evidence can feed in. First of all, as already been pointed out, this is a topic where the needs are growing very fast. The needs are, as I said, roughly doubling. And I'm proposing to be one of the people with needs in 2050, so I want you to make sure you're ready for me when I come. And I don't want to be queuing up with one person in front of me and me never getting to the front of the queue. We're roughly looking at a doubling of needs. We need very much to apply a lot of the learning around palliative care, from palliative care research to the wider health system, otherwise it will be conflicting with the appropriate development of palliative care services. And we need to think very much about how we best combine different kinds of skills. I think getting away a little bit from the notion that there are people with needs for specialist skills and people with need for generalist skills, towards saying everybody needs to have a team of expert decision makers. They may have more or less narrowly defined specific skills around specific symptom management or other needs, but we really need to be thinking all the time about teams and multiple inputs into the decision-making process. The experience of rapidly changing models of palliative care suggests we need to have a skilled but flexible workforce. And again, I think we need to be looking at the way in which we train both in the medical, nursing and therapy and social work areas, as well as in those who manage the delivery of care. Because a long time ago, it was enough to build a building, fill it with, with beds and put people into them. Now we know that's an important part of a much more complex set of services, and the likelihood is that the developments will be disproportionately not in buildings, but will require people to apply their skills in more and more difficult circumstances. And therefore, I think we need to move beyond sort of generalist, specialist categorization, important as it is to have special skills, towards saying, how do we build the teams that are appropriate to the different needs that we're going to be seeing? Really, what am I saying? Well, they were remarkable and they were insightful, but it's got so much more complicated. We can no longer rely on thoughtful and insightful people. We need to rely on bringing the various bits of evidence around what works, what are the growing needs, what are the changing needs, and how can we apply that evidence to improving the experience of people near the end of life and people with life-limiting conditions, but perhaps over a long period, who need the skills, but perhaps more than anything else, the thoughtfulness of good palliative care development. And if you have been listening, thanks for your attention.